It is now 1:43 p.m., August 15th, and we are here in the Senate chamber of the Honorable Jesus B. Mofnes Memorial Building, and I now call this Fiscal Affairs Committee meeting to order. Before we proceed, I'd like to introduce the members of the committee who are present with us this afternoon. We have on my left, Senator Dennis Mendiola. To my right, Vice Chair of this committee, Senator Karina Magofnia. I'm the chair, Donald Manglonia, and with three members present, we have the quorum to proceed. Senators Paul, Carl, Jude, and Selena are hereby excused. And assisting the committee, we have our Sergeant at Arms, Pete Tuwai, our legal counsel, Joe Bermudez, fiscal analyst, Dave Navapon, IT manager, Jonathan Diaz, and also assisting the committee, we have our LA, Devin Macaranas, and our LB staff, LJ Castro. All right, with that, can I get a motion for the adoption of today's agenda?
So move.
Second.
All right, motion was made and seconded. All in favor, say aye. All opposed, say nay. Motion carries. We now move down to public comments. If there's anyone from the public who wishes to make comments today, floor is open. If none, we'll move on to the introduction. Today we have the Commonwealth Healthcare Corporation. They submitted on their budget submission, they've estimated to receive about 100 million, but they projected their expenses to be at 131 million, which leaves a 31.2 million shortfall. However, based on the analysis, it seems like there's about 22.9 that it may be supplemented elsewhere, and so that's something that we can get clarity on. And so the total ask from our analysis comes out to 8.3 million. However, the administration only budgeted or allocated $1, which in definition basically leaves the account open in the event other funding sources can be transferred into that account. Some of the questions that we would like clarity on is this vacant FTEs of 17 million that was in our fiscal analyst terms discounted, as well as the capex of 5.7 million. There's a total of 801 filled vacancies, 284 that are vacant, and 38 that needs to be filled. And so we can get further clarity on that. There's 800,000 that was included in the revised budget submission to the Health Network program, which is very similar to what they're getting now. And so if you can get some information on how what the expenses are for that program and where we're at in terms of the expenditures for the current year. And so at this time, I would like to invite the CEO, as well as any members of our team who will be presenting to the committee here today, to join her up here in the chamber. And at this time, I will hand the floor over to the CEO, Muñoz.
Honorable Chairman Donald Manglonia, members of this committee, thank you for the opportunity to come to you and to present our budget proposal for fiscal year 2025. We would like to begin with a slide presentation summarizing the highlights of our progress, the financial snapshots, funding needs, and the concern of the utility rates. So I would like to turn this first over to Ms. Eleanor Cabrera, who is our Chief Strategy Officer. And by the way, I just wanted to introduce our acting CFO, Vince Camacho, and our COO, Ms. Tiffany Sablan. Thank you.
Chair Manglonia, Vice Chair Magofnia, Senator Mendiola, thank you for the opportunity to allow CHCC to provide some information regarding various updates throughout the year. Of course, the CEO mentioned some of our information regarding our finances and operating highlights, as well as some ongoing challenges. So there to provide a lot of insight into what has occurred the past year. So we appreciate the opportunity. Thank you. And so just as an overview, we'd like to announce some highlights, some recent expansions, new initiatives, of course, provide some progress updates on the audits, as well as provide some information on some key performance indicators on various areas of our corporation, financial snapshots from our current financial standing, as well as some opportunities for improvement and how the matters of Medicaid reimbursements continue to impact our corporation. And then concluding with, as requested, some updates regarding our health network program, formerly the medical referral program. So there have been a number of expansions and enhancements that are ongoing, have been completed and ongoing at CHCC. And one of the highlights is, of course, our primary care access point and urgent care annex in our Saipan facility, which is designed to expedite care for urgent cases and improve access to primary care, and really equipped with additional modern technology and staffed by, of course, a very diligent and dedicated team in our emergency department, with the overall purpose of aligning our mission to ensure enhance our accessibility and improve patient outcomes from the get-go. We have some initiatives through our oncology center, namely the new hair loss prevention program with the scalp cooling system, really in an effort to help patients retain some or most of their hair through, and it's free for cancer patients. It's rarely offered and often costly elsewhere. And so we're pleased to be able to launch this new initiative through our oncology center. We have ongoing efforts to continue the services provided via teledentistry onto Tinian and Rhoda, links our CHCC dental staff on Saipan with patients on Tinian and Rhoda. It's been equipped with equipment and supplies to facilitate that process with mobile carts and webcams, etc. And really to allow the real-time consultations, diagnosis, and treatment planning for dental patients in Rhoda and Tinian. Oops. Through our Population Health Division under our Public Health Services, we're pleased to provide an update on the efforts of our mobile clinic. We've had nearly 100 outreach events stemming from the last quarter of 2022 through the first quarter of this year, with nearly 1,000 patients served. Again, working as part of our overall goals to increase health equity and access to care throughout the CNMI, especially on underserved areas and communities on Saipan. We also have the establishment of our pharmacy drive-through. Some of you were present during the ribbon cutting ceremony. Thank you. And really an opportunity to address some issues with respect to the time needed to pick up prescriptions, wanting to address the overall reduction of exposure to infections, making it easier for our for parents of young children, our manamku, and really unwell patients that have to pick up prescriptions, making it easier for patients to maintain regular medication schedules, even during possibly worsening weather conditions or public health emergencies. We have had the opportunity through grant funding and other measures to procure surgical equipment, one of which is an upgrade for our endoscopy services. It's a medical procedure that uses an endoscope to provide better visioning, enhanced visioning of the interior of the body or organ. It allows for diagnosis, biopsy, and treatment of various conditions with minimal incisions. And that would be our Stryker 1688. We wanted to also share the progress of our audits. We have our single audit contracted with Ernst & Young with the fiscal year 2019 audit, a completed audit for 2019 last month, and projected completions for fiscal year 20 at the end of this year, 21 for anticipated for late spring 2025. We are in the process and working on the single audit contract for fiscal years 2022 through 2024. And it is important to note that all our cost reports are current, and the most current is our recent submission and the cost report completed for September 2023. As for information with respect to building local services capacity, here we have just some graphic information on our average monthly encounters for dentistry. So since 2017, we've had CHCC dentists traveling to Tinian and Rhoda to provide services. And as I mentioned before, teledentistry had begun earlier this year. And this is just to give you a snapshot of the average monthly encounters, as well as for the outpatient clinics here on Saipan, being the family care clinic, the women's clinic, our children's clinic, with the average medical clinic seeing more than 200 patients every day. Here we have information regarding our dialysis treatments. We have both the hemodialysis and peritoneal dialysis numbers, again, running from 2022 through 2024. And that we have, with respect to the PD, it's important to note that it reflects really a per day count and not a per treatment count, because as you may know, PD patients complete multiple exchanges per day. For our oncology encounters, our average monthly encounters, since the opening of it in 2020, our off-island referrals for oncology have reduced by over 90%. For our radiology procedures, as you can see, the CHCC radiology department offers CT, ultrasound, X-ray, mammogram, and bone density scans, and those are the figures of procedures conducted, again, through the same timeline. For our laboratory, the CHCC labs on Saipan and Rhoda are the only laboratories with CLIA certification in the CNMI. This means that these labs may conduct moderate to high complexity tests and are really meeting or exceeding the standards for clinical laboratory testing. With respect to the average length of stay, as an indicator of efficiency for our hospital. In 2024, so far, our average length of stay at CHCC is 4.4 days. The most recent information provided by the American Hospital Association was back in 2019 with the average national rate of 6.2 days. Another indicator is the readmission rate with CHCC thus far in 2024 at 8.8%, with the national average at 13.9%. So with respect to the average length of stay, there is a note there that it does not include several patients that are considered outliers who have remained or are remaining at CHCC longer than medically necessary. So that information is excluded from the average length of stay. To give you some information regarding CHCC's financial snapshots, here is information from 2019 through 2023 with respect to revenues and expenditures. In fiscal year 2023, CHCC revenues have been broken down as such, with 72% being the net patient revenue. And as you can see, that's further broken down to over a third of it being from Medicaid patients, another 14% from Medicare, private payers rounding out just below 20%, and of course 2% at self-pay. And the remaining revenues for the fiscal year being from CNMI appropriations at 5%, which is, to note, represents the transfers of the Health Network program of nearly 5.5 million, and that the actual expenditures for the Health Network program for fiscal year 23 was actually a little over 7 million. And CHCC had covered more than 1.5 million in H&P costs. For revenue and uncompensated care, which CHCC often brings up as a matter affecting our corporation greatly, we have here a graph that indicates the level of uncompensated care as compared to our revenue. And as you can see, during the time of 2020 through our COVID years, we had Medicaid presumptive eligibility, which answers why perhaps the uncompensated care levels have reduced in those areas. But as you can see, in 2023, Medicaid PE expired in May, and this also includes the federal medical assistance percentage of Medicaid's shortfall of $8.6 million that was not remitted to CHCC as a result of the Medicaid federal cap being exceeded for the CNMI. And that and generally our expenditures, the breakdown of what is operations versus personnel. Compounding the issue of uncompensated care and the lack of funding for various healthcare initiatives is information with respect to the Medicaid financing. As you may know, the Medicaid program is a joint federal and local program to assist individuals with low income with their healthcare needs. And with that, we have the CNMI having a portion of local share unmet since the inception of CHCC in fiscal year 2012. There was an appropriation of fiscal year 23 of just under $2 million, and as a result, that local share not received was adjusted to to reflect that information. But overall, through the fiscal year since our inception, we've had the building total of now a little over 80 million that it was not remitted to CHCC. So that is, of course, is since 2012. With all the challenges before us, we also recognize opportunities for financial improvement. We have been addressing our inventory monitoring system so that we'd be better able to track and report the movement of medical supplies, for instance, from warehouse to billable services, working on interdepartmental collaboration to fully utilize surgical suites and the equipment recently acquired there. That we've joined an accountable care organization to promote primary care and preventive visits to reduce the cost of inpatient care for our hospital. We are in the midst of launching and implementing a new EHR, and with that, we anticipate and are excited about a number of improvements that result of that. And we want to express our gratitude for the Senate's passage and support for the recent bill to allow CHCC to amend its corporate powers to establish and participate and assist with the buildup of a separate but affiliated charitable foundation, the CHCC Foundation. So thank you to the legislature. And now I would like to turn it over to COO Crisostomo to provide more information on the Health Network program.
Honorable members, thank you again for having us today. This slide is essentially just a breakdown of the Health Network program and what services we provide. It outlines that for those eligible includes arranging appointments, coordinating hospital-to-hospital transfers, logistics, and of course, other referring providers for continuity of care. Um, Program updates include improved inpatient referral processing times, completing the patient and family user guide, which provides essential contact and logistics information, as well as moving into a new database for all of our electronic files. Our client survey is still ongoing. It's a continuous enhancement to patient and escort experience for continuous feedback. Investments in on-island services have significantly reduced expenditures for off-island care, with oncology being one of the key areas of impact. Since the opening of the center, there has been a 93% decrease in off-island referrals, resulting in substantial cost savings. Of course, we know this allows patients to receive care without having to leave the island, keeping them close to our families. However, it also means that while it saves the CNMI government savings, there is a greater burden on CHCC as far as cost. Further reductions for the need of off-island care is achieved by adding more specialties and advanced equipment. For example, the recent purchase of a lithotripsy machine has reduced the number of off-island referrals for urology cases. Other specialties there are noted, such as ENT, ortho, adult cardiology. The reduction in costs is evident when comparing expenditure on off-island care from 2022 to current. In 22, we see that expenditures were around 10 million, excluding personnel. But with the addition of the on-island specialties and equipment, it has been reduced to about 5.7 million in 23. This decrease reflects the effectiveness of investments in local health care services, as well as minimizing the need for costly off-island referrals. Just really quickly, this one shows the reduction in costs associated with hotel accommodations, logistics, and professional fees, and some other small fees such as office supplies, maintenance, things like that. This is the last slide. It essentially highlights the subsidy for H&P, emphasizing that despite ongoing cost reductions, the CHCC remains in deficit, using its own funds to support the health network program. The budget request for FY25 is about 61.6% less than what was spent on the program in 2019, reflecting significant efforts to reduce expenditures while still facing financial challenges. So thank you again, everybody. We appreciate your time.
Thank you, Tiffany, and thank you, Eleanor. So, as mentioned by CSO Ms. Cabrera, we want to thank all the members who have supported bills that aim to help the safety net health system with addressing gaps in policy, such as enacting the CNMI-wide drug overdose policy for frontline health workers, establishing a charitable foundation, and for establishing parity in coverage and payments for mental health and behavioral health services. There are other bills that both in the House and Senate are still pending, and we need your support, such as bills that would appropriate adequate funding for the health network program, establishing a tax credit for public hospitals and clinics, and creating a just and reasonable rate, a commercial rate for the CHCC. Honorable Chair and members of this committee, the achievements we have shown in these slides are a testament to the exceptional leaders and dedicated staff at CHCC, and some of them are represented behind me. Our commitment to our community drives us to improve the health of our residents. We believe that with sufficient funding, we'll do even more. We urge you to secure the necessary funds to cover the cost of services that CHCC has rendered to Medicaid patients from June 2023 to September 2023 that we have yet to be compensated for. Additionally, we request that you ensure adequate funding for H&P so that vital benefits can be sustained and that the revenues generated by CHCC are appropriately allocated to support patient services. Lastly, we again ask for policy changes to continuously support our progress. Despite the increasing impact of social and economic factors on health in the CNMI, as a safety net provider, we still must provide care to all, no matter the acuity level of care they need and no matter the ability to pay. We ask for this committee to not forget to fill that dollar, not with just 100%. We need more funding, and me and my team are ready to answer any questions. Thank you.
Thank you, CEO, and thank you to your team. Can we just go back to the Medicaid reimbursements, the slide that you have on there? So the amounts that you're indicating, are those separate from what has already, or what's being allocated to Medicaid?
Correct, because they've exceeded the cap in 2023.
No, but the figures that you have there, the 7 million, these are
Is that the one with the?
the 83 million that's.
Oh, okay. So we are reimbursed only with the 83%, or
Right.
the chip, I think, is a little different. I think it's 85%. So we are only reimbursed by the federal share, but there is no local share. Medicaid is a territorial and federal program, right? So there needs to be some support.
Right.
Yeah, so that
So the
83
numbers you're reporting, like the 7 million that you didn't receive
so
in
the
2023, right?
right. So in
That-
2023, sorry, sir. So in 2023, we should have gotten the matching, right, which is about 7 million. But in 2023, we also didn't get the federal share, the 8.6 million,
Okay.
just to be clear.
But the number that you're reporting is the number that Medicaid will be reporting as well, right? The 7 million.
They're reporting it as a match.
Right.
Right. And it is through costs. But again, these are, they're reporting it in order for CNMI to draw down the federal.
Right.
Yeah. But it's not necessarily in cash or in payment.
Okay. And then well, the reason I ask that is because for next fiscal year, the allocation is $1 million less than what they're normally getting, and so that might further impact.
Yeah.
Right.
Yes, it will definitely impact their services, but it also impacts us
Correct.
because that means there'll be more patients who come our way. Because other providers will not accept patients without payment, right?
Has there been a shift towards foreign hospitals already?
Not for Medicaid.
Okay. And then going back to the statement that Ms. Eleanor made in regards to what has been received by H&P amounts to 7 million. Is that what? Did I hear that correctly? Was that fiscal year 23?
Correct.
And that's from ARPA funding, I believe, from Medicaid.
Okay. How much have you received in the current fiscal year to date?
Whatever was appropriated.
So you've already received that.
For FY 2023,
24.
24, it's divided by 12,
Okay. And so they've been up to date.
60 million
Okay.
a month.
How much?
About 60 million a month
No.
for H&P.
Yeah, 16.
60, about 60. About six, yeah.
60 million a month.
I'm sorry, 60,000 a
60,000 a
month.
month?
60,000 a month.
And they've been up to date with that.
Yeah.
What's your average expenditures on a monthly basis for this program? I know it varies, but then how much will your expenditures be at the end of the fiscal year, current fiscal year?
We are spending more than what is being appropriated. That's for sure.
Right. So what's that figure? What do you anticipate that to come out to at the end of the fiscal year?
We pay. Do you have that total? In a month, I'm pretty sure it's about 200,000. at least.
Do you have how that's broken down in regards to
Um,
off island versus inner island?
This we're only talking about HMP outer,
Outside the
yeah,
cinema?
outside the cinema.
And how much of a deficit are you expecting at the end of this fiscal year?
The last from that report, that's $1.5 million as of March. So if that's only for the 2 quarters, then we're talking about probably 3 million of shortfall for the fiscal year.
Okay, thank you. Can you explain what the capex is again?
No.
Capex. There's a
That
$5.7 million listed under, I think, your report as indicated by the term CAPEX, CAPEX.
Did you say that? Sorry. CapEx.
It was deducted in your budget submission. Capital expenditure, maybe.
That's what it is. It's in our budget.
Yep.
Yeah. I believe it is a capital expenditure.
But is that a reimbursement or?
No.
No.
I'm sorry. CFO will answer that.
So for capital expenditure, we from the CFO, we should seek other funding sources if we should not get funding for that. Capital expenditure, yeah.
Yeah. Okay. So that is the capital expenditures.
Yes.
And to date, how much is owed to CUC?
We're actually reconciling with them right now. So we did send a letter yesterday in response to their request for payment. So I don't want to throw in figures until we finish the reconciliation, but I know it's a little bit, it's in the millions.
Is there a current agreement as to your payment plan right
No.
now? So that last agreement that was signed
Expired in May.
and there hasn't been any discussion since then.
There has been communication
Okay.
between us. Yeah,
But you're still remitting on a monthly basis to CUC.
we remitted a monthly payment. Yes.
Okay. What was the discussion? I know there was a discussion on a $5 million. I don't know whether it be a line of credit or a loan to MPOT. Right around the time when the 15 million was discussed.
We have not signed into any loan as of
Right.
now.
Is there still plans to consider it?
Yeah, it's not off the table.
What would that 5 million have been used for?
We would likely use those for whether it's the HMP operations or mainly in making initiatives, like improving patient outcomes and not focusing only on just operational costs. We want to make sure that there's some impact on, and we had provided a list, but some of those have already been funded by us. So we need to go back and revisit the list and, to make sure that it's not focusing on operations, but focusing on initiatives or, programs that will improve the patient outcomes for all 3 islands.
And is that something that could still be considered in terms of reducing the need for off-island referral even further?
I don't think they would. I'm not quite sure if that's something that they would want to fund or use.
No, but in terms of improving the services being offered here, so that.
Oh yeah,
spend
yeah.
that.
The idea is to try to also limit some of
Right.
reduce the referrals. Yes.
Okay. And Has the issue with rev and tax in terms of employee withholdings been addressed?
Mhm.
So
Yes.
everything is
Correct.
okay. At this time, I open the floor to the members. Oh, sorry. Before I do, you're requesting for 300,000 for judgment against the government.
That's usually what we budget.
Okay. Have you had the? Have you paid any judgment in the past?
Yes, we have. Not judgments, but we settle. If
Have you settled anything this fiscal year?
I believe, yeah, I believe so. We did.
How much did that come out to?
Less than 100,000.
Okay. What about last year?
Pretty much the same.
Okay. All right. This time I open the floor to any of the members. Recognize the vice chair.
Thank you, Chairman. Good afternoon, CEO, and to your team. Thank you for being here to help us understand the budget request that you have submitted. So, since we just touched on the medical referral, I know that you guys have been really challenged, throughout the years for many different reasons. But for today, I would like to know what is the long-term plan from CHCC to reduce or eliminate the need to send our patients off island for the type of services that we can't provide here? I mean, there has to be a long-term plan, right? We can't continue on this path every year knowing that we know where we are with our issues. But I'm just curious to hear what CHC's plan for the long term.
First of all, the law is clear that the government has to to appropriate it. So it hasn't been sufficient, as presented. We're taking money from the revenues that we collect from patients that's supposed to go back to providing services to patients here. That's what Medicare wants us to do with their money. That's what Medicaid wants us to do with their money.
Mhm.
Instead, we're taking that money and using it for the services that are going off island.
Right.
But let's also be clear that you can't expect us to have all the services available here. You can't have, even for example, orthopedic surgery. You can't bring a specialized orthopedic surgeon to come here and expect them to do one surgery. You need to send the patient off island. They're not going to do it. They're not going to come here. So the plan is that you're always going to have someone that is going to need to go off island for specialty needs.
Okay.
That's
So-
not going to stop.
So when you say you can't or they won't be able to, help us understand why that is.
Well, first of all, doctors, and maybe Dr. Tudela can chime in, but doctors will not, especially specialized doctors,
Okay.
they do need to have more than one surgery a month
Okay.
to be able to continue to practice that, right? And again, we don't have that population. We don't have a population of 100 patients to go on a
Okay.
cardiac surgery.
Okay.
We
Now I
don't.
understand that part.
Yes, okay. So that's the
smart,
other thing
okay.
too. So it's, the plan is, of course, whatever we can do here. We've been analyzing. We're finally collecting data from medical referral
Okay.
and analyzing it and saying, what are the things that we can do?
Yes.
And that's why we did, we asked the governor to help us fund the lithotripsy.
Mhm.
We also, look at the MRI as a priority, and we apply for this grant, which is, with the endowment, they gave us that money of 6 million. But again, the idea is we're going to try as much as possible to look at what we're sending patients away and what we can do. We will definitely
Okay.
work on that, but you can't stop medical
Okay.
referral.
Okay, so understanding that, that we just don't have the population to
We don't.
to have those type of services here. Um, I know that I don't know if we still do, but do we still send patients to Guam for like an MRI scan or stuff like that?
It depends on the current regulations, and the regulations is does not cover, for example, pain management. Something that's chronically managed are not covered under the current regulations.
Got it.
So the MRI, they can go if it is an emergency, if it has to do with the care. So what is the patient actually getting it for? If there's a diagnostic service that is needed to treat the patient, yes, we will send that patient
Okay.
and we will pay for it through getting the MRI.
Okay.
But for other chronic pain management, that is something that we are actually anticipating to be performing here in the CNMI
Okay.
once we get the MRI.
Okay. So you're saying that we currently don't have one.
We don't, but we also don't send them on referral
Got
if
it.
it's just for
Okay.
chronic medication management.
Okay. I
Sorry.
recall back maybe a couple years back, there was a public law that allocated some ARPA funds for an MRI equipment. Can you give us the status of that?
Sorry, that was never
Um,
transferred to CHD.
okay, so Public Law 22-8 for the MRI was never transferred to.
No.
Okay. Okay. And then I believe I read in the paper that someone who was very generous from, was it New York, somewhere from the East Coast,
Foundation, the
right?
Helmsley Foundation, yes.
Donated the MRI.
They donated the MRI, the building, the generator,
Okay.
the operations for 1 year
Okay.
is included in that.
Okay. Well, that's definitely great news. And so we can we go now to your financials? Can you tell us what is the balance of your outstanding receivables as of, let's say, August 14th of this year?
The balance. Receivable? Yeah, you don't have it. I believe we will send that to you. It's
Okay.
still quite a lot.
Okay. And then can you just tell us a percentage of what, so on a monthly basis when you send out your billing, how much of that goes into receivables on the average?
Um, okay. Do you want to talk? Sorry.
Sorry, just to clarify your question again, how much of that goes into receivables?
Right. So let's say this month you bill $1,000. How much of that realistically will you collect on versus what goes into your receivables waiting for payment?
I think
Depends
there's
on
we're still confused with that question. Sorry, it's not the way. I think basically we are behind in our billing, so everything goes into receivables, right?
Oh,
Yeah,
okay.
right.
Okay. Okay.
So
that's,
we're
that's
behind,
clear.
right?
Okay.
Okay,
I mean,
just to
typically that
clarify.
doesn't happen, but I think
Yeah.
you're right.
Right. I mean, our billing does require a lot of documentation. A lot of the billers, when we're sending claims, for example, to Calvo's Insurance, they do
Mhm.
require supporting documents, and that does take time.
Sure.
Yeah.
So, in most places, when you go in for even for a quick checkup, the minute you check in, they get all your information. And then by the time you check out, they produce a bill for you to pay, or whether or not it's billed to your insurance. But typically, the billing is done on the same day. So, is CHCC kind of um, not doing the same practice?
It's not. It's usually when they do that, they are the services are just clinic services. What we do is there could be some diagnostic tests that they need to do. Some require prior authorization, so those things are not necessarily just. I mean, they could do that. We would do that if it's just a clinic visit.
Mhm.
Absolutely.
Okay.
There's no problem with that.
Okay.
But when there are other tests that is involved, and because we have those tests and we are the ones who do the test, those things require, like
Okay.
I said, prior authorization, or again, it could be making sure that culture and sensitivity, those things have to, you have a second
Okay.
layer before they actually bill for them.
Okay. And the reason why I asked that, because I think in your presentation, right, it gave us a breakdown percentage wise of what the revenues are composed of. So I think it was a percentage for, geez, what was the word? Net patient 72%, grants and contributions 19%, and then CNMI appropriation 5%. So it kind of gave us an idea of what sources are funding your revenue. So help me understand this net patient revenue.
What is your?
Okay, so the net patient, like what does that mean? I don't know what that means.
So you have CNMI appropriations. Let me just pull out the
Okay,
file.
yes.
Sorry.
So I think the other
Because I
ones
can
are
see.
self-explanatory. I'm just not really sure what net patient is defined as.
So net patient revenue is coming from actual revenues from the patients, whether it's insurance, right? So you have Medicaid, Medicare, private
Mhm.
payers, and
Okay.
self-pay. Yeah.
Okay, so this brings me back to my question earlier about the receivables, right? We are projecting a revenue for FY25 of a little bit over 100 million.
Yes.
And I was just wondering how much of that 100 million is really realistically going to be collected.
I would probably. I mean, you have 2% of self-pay. About 98%. It should be realistic.
Okay, and that's why I was asking about the percentage of
Yeah. Okay.
receivables, right?
So
Because
it's
I wanted
about
to know
2%.
what was sitting in your receivables, um, how much is sitting in your receivables, what percentage of that is actually, from the total revenues that was generated. I'm assuming that's cumulative from even
Mhm.
prior years,
Correct.
right?
Correct.
So I just kind of wanted to get a ratio of what it looks like when you generate revenue versus what's sitting in your receivables. So
Correct. Yeah, I understand.
okay,
I would, just tell you that when it comes to prioritizing our cash cow, if you want to call it, Medicare and private payers are definitely a priority to bill,
Yes.
especially when we're not getting appropriation and Medicaid is short, right?
yes,
Yeah.
okay. What is your balance of cash available for the operations of CHCC as of August 14? And will it be able to cover its payroll and all other expenses and obligations when they become due in September? So do you have enough cash right now in your bank to cover?
Not up to September,
Not up to, okay.
but we definitely have enough for payroll and yeah. I mean,
Okay.
we're managing it.
Okay. Okay. Um, and then so the capex of 5.7, do you know what those projects are for?
So the capex, in my understanding, is for whether it's grants or we're going to be getting from big projects. Yeah.
Yes. Right. So can you share with us what those what those projects are? Are you able to?
So, yeah. He doesn't have it right now.
Okay. Maybe you can share it with us at a later time. Okay. And then there's an adjustment of 17.2 million on the expense. I think under the budget deficit, right, you add back vacant FTEs to be filled only based on availability of funds. So you're essentially removing that funding for FTEs based on
Right.
your.
So
Okay.
if we don't have, if we don't get the budget funding or we don't produce enough revenue, then we don't plan to be filling
So
those
would
FTEs.
these FTEs be dollar funded then, just to ensure that the FTEs
So it'll
are
be
available?
reduced.
Okay.
The budget.
Okay. Okay. Um, and so I know that in your budget request for HMP, you had submitted $6.5 million.
Yes.
And on the governor's proposal, only 800,000 was allocated. And so,
You need to find more money.
okay. Yes.
Sorry.
No, yes. Okay. I think that's going to be one of the major discussion during the deliberation between the two houses.
Okay.
How much in federal grants will you be expecting to receive in FY25?
You sent it to me.
So typically, so grants are changing every day. We get money every day. Grants expire every day, and so generally about maybe 50 to 60 million
Okay.
in grants.
And of that, how much is is estimated for indirect cost reimbursement?
So right now, CHCC uses just the 10% de minimis rate,
Okay.
and some of the grants, though, especially like equipment or project grants, they don't allow for indirect costs.
Okay.
Yeah.
Okay. Do you know what your year-to-date expense right now for medical referral? I think you kind of asked that, but you asked for the remainder of the fiscal year. But would you happen to know what your year-to-date expenses?
For medical referral.
Yeah.
We have about 6 million. We're projecting 6 million. So
Are you
we're actually at 3 million right now, right?
3 million? Okay.
Yeah,
So
3 million.
year-to-date about 3 million.
Yeah,
Okay.
that's what we
Okay.
mentioned.
And then I believe the chair asked about the 300,000 that is requested for judgment against government, but you had clarified that it's for settlements and about 100K per year. Are you able to share with us what types of settlements those are?
I would talk to your legal
Okay.
counsel.
Okay. All right. That's all I have for now, Chair, for 111. Thank you. I yield.
Thank you, Vice. Sorry, before I recognize Senator Mendiola, just to get clarification on some of the responses that were given to the Vice Chair's line of questioning. In regards to the net revenues, does CC have real-time access to like an individual's deductible? And so, like, are we
Yes.
starting from the beginning of the year forward? And are these also accessible by our Rhode Antonian clinics?
Yes,
Does that make sense?
we do have real-time access to deductible information. However, it also depends on when bills are sent to the insurances. So if a patient pays a part of the deductible at one of the private clinics or at CHCC, that real-time balance or deductible amount on the websites depend on whether or not that bill was provided to the payer to allow for the adjustment. So
How is CHCC behind in a lot of these billings to the insurance companies? So that deductible can
as
be
far as
adjusted.
deductible, we have put measures in place. I think it was about last year or so that especially for those paying deductibles, that we expedite those bills specifically, because we've had those concerns before, so we've addressed it in that sense. However, it's still, if a patient were to pay $20, for example, at another, or $500 at another clinic, we won't see it on our end if that clinic did not bill and note the $500 payment.
Right. But what's the processing time on average? Would you say CHCC sends out these billings to, especially these private or the ones that are paying deductibles?
And there is real time, like a real time log that is shared between our patient access team and our billing team to flag those. So they're checked on a daily basis and closed.
No, I mean on your end, on CCC's end, in sending these billings so that these insurance companies can log it in
Right.
on their
It,
real time. Is that
so
what you're saying?
when we see that a patient has paid and we're able to close it, like if it's an outpatient clinic, for example, outpatient service, because those codes and documentation should be readily available, we can send the bill out right away. If they paid on a deductible for an inpatient visit that has days of accumulation of notes and things like that, it's not upon discharge, right? Because we have to go through that, sift it, code it, and then bill it. So it depends on the type of visit, but we do submit those as soon as we
Okay.
get them.
All right. Senator Mendiola.
Can we go to the slide of the matching fund, please? Just have some clarifying right there. This one. So we go down on fiscal year. I'm looking at local share received. Is there a specific reason why in 2018 or 2018, 2019, 2020 the amount went down and then we went back up in 2023?
So in 2019, there was a law from the U.S. Congress that increased the FMAP to 100% because of the super typhoon Yutu.
So it reduced the amount.
Reduce the amount.
Okay.
Right.
And then you stated in 2023 there was no federal on Medicaid, correct?
No, we did receive 52 million, and that should have been matched with 7 million. But
We did not.
But there is more than that. We should have gotten, if you add the 8 million, that would have been supposed to be at least 61 million.
60.
So we were short by 8.6 million.
Okay, got you. Sorry. And then back to Senator Magofnia's point about not having the specialty clinics and trying to reduce the amount of medical referral. And I can bring it back to Rhoda too, because everybody in Rhoda kind of wants some of these specialty, but it comes down to supply and demand, and then making sure that even if we bring all these specialty or specialized doctors down there, it will cost us a lot more just to maintain that. And then, like you stated earlier, we're not gonna bring a specialized unit just for one patient. It doesn't match the operational cost versus what's the expectation. So I wanted to bring that to here as well. We've reduced a lot of our patients, especially in cancer, right? Our oncology, right? I see that 93%. Is that the right number? What about what is the specialty for heart? Cardiologists. What about that specialty? Is that something that we're trying to address here in the CNMI? But surgery, we would still require referral, correct? Thank you.
So are you talking about cardiothoracic surgery, like open heart bypass?
Yes, sir.
So just like the other specialties, if you don't have the supporting team, you don't have a different type of CT surgeon, you don't have the backup for any type of unforeseen circumstances, it is dangerous to do that procedure here. We don't even have an angiogram suite. So, we don't have the special OR to do it.
Wow.
And same with the other specialists. If you don't have enough cases, you can't do.
So it really comes down to just cases, right? It's just wanted to clarify that. And it's
proficiency. So if you have a doctor that does, one case every few months, they're not proficient to do these confidently or competently. So there's that as well.
Okay. Okay, just wanted to clarify that, and the reason why I wanted to clarify that is because, of course, one of the outcries always, amongst this issue about having these specialty clinic, because we coming from Rhoda, a lot of the people are always complaining about the referral time, and sometimes we don't meet that necessary need for medical, right? But again, it comes down to proficiency and making sure that
Yeah, and sir, I've been down to Rhoda several times this year, and a lot of it also starts with the patient. So I always talk to them about, you wouldn't be in this position
if you don't wait,
if you don't, control your weight, you don't take your medication, you don't wait till it's, last minute. So I think working on something where you put our resources in prevention.
I was
Yeah.
alluding to that, and I guess to just
Mhm.
help that and mitigate that is really, and your team has been doing a great job in trying to, stay proactive and
Yeah.
trying to, teach a healthier lifestyle. Even if we're talking about, like, for example, chewing bironat, I'm starting to see a lot more people,
Yeah.
quitting chewing bironat, because now there's an advocacy out there, and everybody's getting smarter about some of the causes of this
Mm-hmm.
cancer, for example, and likewise the diet,
Yeah, regrettably,
Yeah.
it's coming back. Well, it's harder to keep a good diet because it's more expensive,
Yeah.
or they always have everybody in this room has a anniversary to go to, wedding, a funeral.
party every weekend.
so I think culturally it's going to be a very tough thing to do.
So it's really just really trying to help change the mindset and culture in the culture, and trying to stay
Mhm.
active and stay healthier,
Mhm.
and it'll because we will not, as per what you stated, we will not remove medical referral or referring patients off island, because again, we can't have every services on island
Mhm.
that is required, especially specialty services. So I just wanted to point that out.
Yeah.
And I know your team has been doing a lot of great job. I've seen a lot of changes in the hospital. I see a lot of new hospital beds. A lot of there's a lot of change, and I just like to commend your team for that. Thank you, Mr. Chair.
Can I just make a correction? The 52 million does include the 8.6. Sorry, just to clarify.
Thank you, Senator Manula. Vice Chair, go ahead.
Thank you, Chair. I just kind of wanted to follow up, and I guess I wanted to know if the non-payment on the local share is just due to lack of funding from the government, or is there more to the non-payment?
Let me just clarify too that we are so there is the certified public expenditure
Okay.
methodology that does exist for payment, and while that amount is definitely not we're not necessarily expecting it, but it should be valued.
Sure.
What we're asking for is that it should be valued, right? You have $7.3 million of our expenses that are included in the certified public expenditure methodology of
Yes.
payment. But that $7 million is coming from our expense.
Right, and that's why I'm trying to
Yeah,
understand that, right?
right.
Because you guys have to get paid back for whatever money that
Absolutely.
whatever sources you use to supplement those,
Right.
right? It has to go back to you.
Right.
And so I'm just trying to understand is the not when you guys don't receive that share from the local side, is it because there's lack of funding on their end, or they're just not in agreement with the amounts that you guys are presenting? Or
Well, again, we're not necessarily asking for it to be paid. What we're asking for is to think about the policies,
sure.
whether it's the tax or it's the
Okay. So
it's
some
there-
ways to
there-
offset it.
it should be recognized as a government expense and not so much a CHC expense. Right now, it's being treated as a CHCC expense. However, the rationale for not paying us the $8.6 million is because it's a government expense.
Mhm.
So it needs to be clear.
clear.
Is it a government expense or a CHCC expense? They're not paying us $8.6 million because they're saying it's CNMI, But then when you're asking them to pay the $7.2 million, you're saying, oh, no, that's a CHCC expense. So those are things that are still need to be ironed out and need to be clear. We need to get paid for the $8.6 million. That's for sure.
Okay.
CMS recognizes that. Medicaid recognizes that. CNMI Medicaid recognizes that. In other territories, and I'll show just as an example, USVI also ran out of money from their capped funding. The legislature appropriated that, the gaps. We are not seeing that here. And so
Okay.
somebody needs to pay it, and that's why we're asking for
Okay.
some kind
And
of.
so is there a plan to move forward to try and, I guess, resolve the issue of clearing the books, and whose expense is it really?
It's marked as a CNMI expense. That's according to the books of Medicaid.
Of Medicaid.
At least Region 9 tells us that that's a CNMI expense.
Okay.
So it's a CNMI debt to CHEC. According to Medicaid
Yes.
and CNMI Medicaid.
Is
Just want to
that
be clear
reflected
about
on
that.
the CNMI's books? Do you know?
I don't know how they enter it in their
Showing as a
books.
liability on their.
They're supposed to show that as a liability.
Okay.
Yeah. They should, right?
Yes.
Right. Thank you.
Okay. Thank you for that
Yeah.
clarification. I think we'll reach out.
All right.
Yeah, so
to-
help me understand again, and this is surrounding those questions and the understanding of it. So, for example, the 7 million that we appropriate to the Medicaid agency is meant for the local share of this pot of money, but then instead of them paying the 7 million,
Just
you're using the CPE to.
No, instead of paying so if you're appropriating $4 million, it is likely going to the private sector. It's likely going to off island. It's likely going to, we are getting some of it, but it's not, not the amount that you're appropriating. The $4 million is mainly going to the private sector. So, we are having discussions with Medicaid agency here to think about other ways to make it less of a burden to the CNMI. But
But the CPE is kind of like considered that share to get the remaining 83%. Is that my understanding?
right. I mean, so every provider here in the CNMI gets paid 100% by Medicaid, right?
Right.
They get the 83% from the federal and then 17% from the local. CHEC is the only one that gets paid only 83%. So we're even if
So of the 7 million, for example, that gets appropriated to Medicaid, how much of that do you think goes to the private versus how much?
about 90% it goes to private.
So that they don't turn them away, or
Correct.
because like with CCC, they're just gonna expect CCC.
But it is in the law, the CNMI law, that CHEC should be prioritized. It is in the law. But anyway, that's again, that's the way.
When you say private sector, you're talking about like the services, the service providers that these patients go to,
Yeah, the clinics here,
clinics.
and then the
clinics,
off island.
and also
Off
off
island.
island, off
Okay.
island. Correct. Yeah.
Okay. Now going back to the discussion on the specialty services, has there been any discussion with I don't know, maybe GMH or GRMC in terms of which one of the entity or which one of the jurisdiction could possibly address the need, and that way we can have like this reciprocal agreement where they send their cases here and then on specific specialty, and then we send some of our patients there on other specialty that can't be covered here. I mean, if you're going to consider the Micronesia as a whole as one, let's just say one entity, and look at the cases between all the 4 islands, is that something that could be considered? And
Yeah, it could be considered, and this came up a few years ago when GRMC first opened. We kind of had that talk, but it comes down to how much, money is transacted between, CNMI and the private hospital. One of the things that happened, and you can clarify this, was they weren't accepting Medicaid unless they paid up front. Medicaid patients that they see. And then most recently, most of the interest comes from the actual provider themselves who work there. They reached out to me. For one is a neurologist who wants to do outreach. And so we have started that conversation. And hopefully we can, under a bigger agreement between CHCC and GRMC, which would happen at the highest level, to forge that agreement to include other specialties. Otherwise, it's just piecemeal, where one person has an interest to come out here. We provide them an opportunity and we pay them for it to see a bunch of patients, once or twice a month. We also have a neurosurgeon that comes down to Saipan now, and same agreement. His interest was to come out here to provide services to our population once or twice a month. And then, again, we pay for that as well. So in terms of having something more consistent, more predictable, more organized, I think that's going to have to occur between corporations, probably with the CNMI.
Okay.
Can I add that? So you need to fix Medicaid. That's the bottom line. And when I'm talking about fixing Medicaid, we really do need to remove the cap. So I've asked this body, and I think I have asked also the House to come up with a resolution. There's already a resolution coming in. Or a statement coming in from Congressman Sablan, from the governor, about removing the cap for Medicaid. There's a lot of discussions, a lot of things that we can do. We can't. Sometimes we hold back because, as Dr. Tudela mentioned, there's a conversation we can have about having a provider come to Saipan, but you have to use local Medicaid, and if you're cap funding, how do you expect to pay for it? That's the question.
And have you brought that issue up to the governor in terms of having that as an I-02 consultation?
We thought about, yes, we've kind of shared that, yes, and we're hoping to meet with Mr. Sablan also to discuss about this.
Okay. So I guess just in closing, of the funds appropriated to Medicaid, CCC is not getting any percentage of the local match.
I'm not going to say we're not going to get any. I'm just saying that the priority, because it is a certified public expenditure for hospital services, right? Then the priority goes to those that require a drawdown. You have to show the cash before you draw down, right? So for private providers, in order for them to pay, they have to present the match. They can't draw down the federal without the match. For us, we can draw down the federal because they're, again, CPE, right?
But are you up to date in terms of
Yes.
the federal match that you're expected to receive?
That's why one of the reasons why, as mentioned in previous hearings or discussions, is that while the audit was definitely a priority for us, during the time when Medicaid wasn't paying for 4 months, the priority was making sure that the Medicare cost report was up to date. So we're up to date with our Medicare cost report, because that determines how much we're going to get paid by Medicaid, and it determines how much we're going to get back from Medicare as well. So that was, during a cash crunch, we needed to prioritize the Medicare cost report.
So how much would you say as of last month are you expecting to receive on the federal share?
We get about 4 million a month. I believe 4.4.
Okay.
Yeah. Okay.
Any other questions from the members? Vice Chair?
Thank you, Chair. Just one. So speaking of the audit, is there a reason why 2019 was just completed last month, and then I know 20 will be completed at the end of this year? Why is it so behind?
So starting with FY19, as you saw on the slide, it was the first time that CHCC was responsible for bidding out and contracting our own auditor. So all the prior years, it was the government that did the contracting. They included us in their audit with Deloitte, and then this is the first time as well we're working with Ernst & Young. So Yeah, so it's the first time, and so the contract includes all 3 years, and it's ongoing at the same time.
So
Yeah.
so when did CHCC pursue the audit for the 2019?
Last year, I
Last
believe.
year.
Yeah.
And prior to that, were you guys not getting audited for 2019 because you were under the understanding that the government was going to take
No,
care?
so FY18 was already FY18 was completed late,
Mhm.
and that was from the government. And then for FY19 moving forward, we had to do
Got
the
it.
Okay.
Because
Contracting.
I know
moving
that the
forward.
central
Yeah.
government too is catching up with their
Yeah.
audits, so that makes sense.
Yeah.
Okay.
we're,
Thank you.
we're catching up too, but obviously we also need them to,
Yes.
right?
Yes. Thank you for the
the procedure.
clarification.
Thank you.
Yes, because we can't understand that just looking at the presentation, right? So we need a little context. Right. Yeah. Thank you. That's all, Chair. Thank you.
Thank you, Vice. Sorry, just a few closing clarification on the House version of the budget. It looks like they've increased your operations ceiling by 6.5 million. Is that at your request? So right now, based on your budget submission, the ceiling that
Is this for HMP or for?
no, just for total under CHCC.
Oh, thank you. Better than
The operations that you submitted in your budget request was at 51 operations alone, 51.5 million, but the House increased the ceiling to 58 million. Is that did that come from CHCC?
Whatever we submit to them is the same what we submit to you.
Okay, so there wasn't any
No,
supplemental
there was
requests
no
just from you guys.
supplemental request. I'm not aware.
Okay.
Yeah.
And you also brought up the CUC rates.
Yes.
I know Miss Eleanor is very aggressive in trying to get committee member or committee chairs to look at some of the bills proposed. I know that the Senate did adopt and pass that legislation. Any update as to where the status of that legislation?
No, there is no update currently.
But similar requests have been made to.
Yes, of course.
Okay, because I know that particular bill. I know so there's this
Yeah.
challenge with the two separate legislation, but I think the one that the Senate passed was strictly focused on CACC, and I know that's really something that is affecting your operations in terms of billing and expenditures, and so
Yeah.
I wanted to see you.
I mean, we definitely need that. I mean, that's again, looking at the. I just want to clarify one more thing. Sorry if you don't mind. When we're talking about the FMAP, just be mindful that this is not on charges. This is on costs, right? So we're not billing Medicaid 60 million, right? We're only billing them the cost, right? Not the additional charges or whatever we charge other providers. So just to clarify that, and I think that's the our plea is that think about what could have gone to us, through local share, and then look at the regulations and policies that are preventing us from, I mean, because we pay $7 million. I mean, if we get the $7 million match, we will pay the rates, whatever. We will pay CUC, right? We'll pay whoever wants to be paid.
Well, thank you. I mean, whatever recommendations you have, I mean, we've been very supportive of some of these legislation and requests that has come through both houses, and so before we excuse you, I mean, I know you have a full team with you. If there's anything that anyone would like to offer at this time, I mean, I'd like to offer that opportunity now.
The chairman means to lobby.
If not, I think our fiscal analyst would like to just provide a brief remark or have a question.
I just want to, can you bring us back to the revenue slides? I just want to bring back the vice, concern on the revenue side, on the net revenue. Yeah, you're looking at that slide there showing 77%, right? 72% portion of the net revenue. She was trying to clarify how much of the 100% of the service revenue, patient revenue that would be generated represents the provision for uncollectible accounts. Because when you look at it, it's net patient revenue, right? So we're assuming that that is not the gross revenue. So and that's where it's coming from. Out of that dollar that is billed, how much of that dollar is uncollectible? So we're saying that if you look at that slide, I'm saying that the third-party payers, like for example, the Aetna, private insurance company that would take care of the insurers, not the patient, right? I just want to know who are these people that are not included in there in terms of the net revenue. How much amount of revenue we're talking about that we're just taking out from the gross revenue that you're representing as net patient?
So you're asking, out of the net patient revenue, I'm not sure if I'm going to answer your question, but basically the net patient revenue, there are, of course, allowances, there are, insurance removals, right, where they're based on the contract. And, when we set our charges, we take those into account. And that's why when we do our fees, it stays at that particular rate, right? It's based on allowances, on deductions, on uncollected services. So, this was a question asked a while back when we were raising our fees, right? There was an uproar of, well, why are you raising up your fees? And we're saying, well, when we calculate it, the bottom line is the only people that's really going to be hurt with these fees are the tourists, right? The people that are going to be paying 100%, or basically those that are maybe uninsured, but they can't afford, right? The ones that are uninsured are likely going to be falling into what they call the sliding fee program, which really is providing free services to these people. We're practically going to be providing, and we're not going to be collecting. Just be mindful that there is a group of they're going to be able to not pay.
All right. And one
Yeah.
more, Mr. Chairman.
Yes.
With respect to the audit of FY 2019,
Yes. Yeah.
can you give us how much the question cost was discovered, if any, or what's the audit opinion?
Sure.
Yeah.
Just to clarify, testing has been completed, but the audit, we're just waiting for it to come back to us for completion. So we don't have that figure yet. Yeah. I just wanted to add about the revenue, the projection. It's cash basis, so not accrual basis. So the receivables are not included in those projections. So yeah.
Thank you. If there's nothing else from the members at this time, CEO, if there's anything you'd like to close out with, I'd give you that opportunity.
Thank you. First of all, thank you for the opportunity. And it's, we just finished our Medicare survey. Just wanted to say that, there's standard findings, but that is actually the best survey result that came out of CHAC. And, this is because of the work. If our employees are really committing to improving patient care and ensuring patient safety. So, just to please thank your nurses, your doctors, your healthcare workers, because they've really done a lot of great things to get to that level. Those standard findings, no conditional findings, and that's just amazing for the hospital here. So I'm very proud of their team, and we can do more. And I don't believe we've ever had a chance or we've ever had done anything worse than what you expect of us. And so, every time you give us money, we will make sure that it's done, given to the patient care. It's all patient services. So please continue to support us, whether it's regulation or funding, preferable funding, but of course, regulations is also good. Thank you so much.
Thank you. And with that, again, thank you, CEO, and to the rest of your team for coming in here in support of your argument for a bigger budget. We appreciate all the work that you guys have done and continue to do, and continue to have this dialogue with the committee and the members of the legislature to ensure that the policies are up to date, as well as something that would benefit both our only public hospital as well as the patients that you guys serve. And so with that, you are hereby excused. And if there's anything that we need clarification on, or if there's something that you feel that you probably we didn't discuss, but you would like to share with the committee, please feel free to include that in some of the reports that we'll be expecting. And so with that, members, we move down to the next item on the agenda, and we do have I'm proposing that we push DLNR from the 26th or 7th, I think, to next Wednesday, if that's okay with the members, and just so that we can kind of close out our budget hearings so that we can focus on the budget deliberations. We will also have an informal meeting next Wednesday afternoon, which I shared in your email. So please, if that date doesn't work, let me know. Any other announcement from the members? If none, can I get a motion for adjournment?
So
All right, motion was made and seconded. All in favor, say aye. All opposed, say nay. Meeting is hereby adjourned at 3:09 p.m.